I'm John Strum, and this is RealTalk MS. It's May 28th, and we have a lot to talk about. But before we get into today's episode, I want to remind you that on June 12th and 13th, the National MS Society is hosting the 5th annual Black MS Experience Summit. The theme of this year's virtual summit is Unstoppable, Rising from the Disruption. And if you haven't yet attended the Black MS Experience Summit, I hope you'll plan on making time to attend this year. You'll find a space to connect with others who understand what you're going through. And you'll find an event that's designed to let you put aside the stress that MS can cause when it disrupts your plans, and instead provides you with an opportunity to connect with people who can help you move forward. This year's Black MS Experience Summit includes professionally led breakout sessions on managing MS over time, exploring MS treatments and medications, sexual health and intimacy with MS, empowering your MS circle of support, using mindfulness to reduce stress and enhance your well-being, and diet, exercise, and healthy behaviors for living your best life with MS. You aren't alone on your MS journey. The Black MS Experience Summit will connect you to a supportive community that you can tap into to get what you need and give back to others. The Black MS Experience Summit takes place on June 12th from 1 to 4 p.m. Eastern Time and June 13th from 1 to 3 p.m. Eastern Time. It's virtual, it's free. It would be a shame to miss it. If you're interested in learning more, or if you're ready to register for the Black MS Experience Summit, you'll find a link in today's show notes. We're just a couple of days away from World MS Day, which takes place around the world on May 30th. And I want to take this opportunity to refocus us on some of the challenges faced by people with MS who are living in countries all around the world. MS impacts about 2.8 million people around the world. Although there are so many challenges associated with just getting a timely and accurate MS diagnosis that I feel fairly confident that number is probably significantly understated. That's one of the reasons that the theme of World MS Day 2024 is diagnosis. The Atlas of MS is a joint project between the MS International Federation and the World Health Organization. It's unique in that it doesn't reflect a standard review of published literature. Instead, the research team that updates the Atlas of MS reaches out to patient organizations and experts in every country and asks them to provide the most up-to-date information on MS in their country. And according to the 2013 update of the Atlas of MS, 83% of the countries around the world have barriers that prevent the early diagnosis of MS. Globally, the most common reported barrier is a lack of awareness of MS symptoms among the public and among healthcare professionals. In other low and lower middle-income countries, barriers include the availability of qualified healthcare professionals and the availability and cost of necessary diagnostic equipment and tests. MS is diagnosed by a set of diagnostic criteria called the McDonald criteria. And the Atlas of MS shows that the use of the most updated McDonald criteria in different countries correlates directly with a country's wealth. The McDonald criteria is used by 98% of the high-income countries in the world, but in less than 40% of the low-income countries in the world. And the most common barrier to using the McDonald criteria is a lack of awareness or training for neurologists. It's been well established that the early use of disease-modifying therapies leads to a better quality of life and better patient outcomes. But access to DMTs is not universal. 14% of the countries surveyed by the Atlas of MS report having no approved disease-modifying therapies. This number increases to 60% of African countries and 70% of low-income countries. The Atlas of MS shows that a quarter of the countries worldwide do not use high-efficacy disease-modifying therapies. This number increases to 50% when you look at lower middle-income countries, and 100% of low-income countries do not use high-efficacy DMTs. I guess you can say that access to medication isn't necessarily a problem when that medication is simply not available in your country. Or you could say there's a much bigger problem here. 72% of the countries worldwide cite barriers to accessing disease-modifying therapies. The most common problem in half of the reporting countries is the cost to the government, the healthcare system, or the insurance provider. In addition to costs, experts in low-income countries point to a lack of healthcare professionals and a lack of knowledge about disease-modifying therapies among the healthcare professionals that are available in these countries. And in almost half the countries worldwide, even when people can be started on a disease-modifying therapy, they face the challenge of being able to receive future doses of that DMT without interruption or delay. 27% of these countries cite irregular supplies of DMTs. 19% of these countries cite delays associated with people needing to have their reimbursement renewed. And 13% of these countries attribute these delays to having to continually take tests to prove continued eligibility. When it comes to MS care, we see another fragmented global picture. At least 1.8 million people, that's 2/3 of the world's MS population, live in countries that do not have national guidelines for the diagnosis and treatment of MS, and do not have national standards in place to guide MS care. In many ways, at least some of the needs of people living with MS anywhere in the world seem to be the same. At the very top of that list, they need access to quality health care and access to affordable medications. It's when you dive a little deeper and begin to analyze the socioeconomics of different countries and the structure of different healthcare systems that these access problems become a little more clear. Joining me to discuss getting an MS diagnosis outside of the U.S. and some of the other challenges facing people with MS no matter where they live is Rachel Horne. Rachel is a journalist in the UK who was diagnosed with MS in 2009, and she's the driving force behind establishing the Rachel Horne Prize for Women's Research in MS, which is awarded by the International Women in MS in recognition of outstanding contributions to research and understanding and treatment of women's specific health issues in MS. In a moment, we'll meet my guest, Rachel Horne. Rachel Horne is a journalist in the UK who was diagnosed with MS in 2009, and she's the driving force behind establishing the Rachel Horne Prize for Women's Research in MS, which is awarded annually by the International Women in MS. Rachel is also an MS activist, and I find her posts on X, formerly Twitter, are always worth following. Welcome back to the podcast, Rachel.
Oh, thank you very much, John, and thank you very much for having me.
We're just a couple of days away from World MS Day. And this year, the theme of World MS Day is focused on diagnosis. So can you tell me what it's like getting an MS diagnosis in England?
Gosh, well, this was nearly coming up to 15 years ago. For me, because I didn't have any, or looking back, I didn't have any obvious symptoms. So it was an awful shock for me. It did happen, though, very quickly because I had overwhelming symptoms, which led to me being admitted to a hospital and treated, diagnosed and treated there. So I think my situation was slightly unusual in that it wasn't one of those things that over a course of several years, I said, look, I know something's off. I do think compared to the last 15 years that things have certainly got better in the UK. And I think that's because there's a greater awareness of MS and the symptoms. and there is more of a rapid diagnosis. But I think at the same time, it can be very difficult if perhaps you don't have a GP who is familiar with MS or tends to dismiss your symptoms. And also, I do think it's worth pointing out. The MS Society of the UK has just recently, in the last week or so, come out with a survey saying in 2019 they suspected there was 130,000 people in the UK living with MS. Now they think, as a result of their survey, it's more like 150,000 people. And 7 out of 10 of those people are women. And what's also more interesting is that out of the, say, 45 countries in Europe, we're very much at number 44 in terms of neurologists. So that means that there's a real shortfall in the amount of neurologists practicing in the UK. And I have to think that probably does have an impact on whether or not people are seen by a neurologist quickly, and if that neurologist specializes in MS. So I think we do have a growing awareness, but at the same time, I think for any in the future, and whichever government that may be, we do need more investment with more MS nurses and more neurologists.
Which pretty much leads me to my next question. As you just alluded to, we know that an early diagnosis leads to early intervention, and that leads to better patient outcomes. The MS International Federation's Atlas of MS shows that 83% of the countries around the world have barriers that prevent an early diagnosis of MS. And the most common reported barriers is a lack of awareness of MS symptoms, not only among the public, but among healthcare professionals. So how do we improve that?
It's a big question, John. I think it's multi-pronged, isn't it? It's about growing awareness, but it's also about investment, and it's also I remember, and as I said, I'm not set in stone, but as you very well know, John, and you've heard repeatedly, diagnosing MS is not as simple as a simple blood test, and it means a strong reliance on a series of blood tests, a lumbar puncture or a spinal tap, or an MRI to see if there's lesions in either the brain or the spine. And what happens when you don't have? I mean, there's an MRI is an expensive piece of machinery, and a lumbar puncture, it can be quite challenging to carry out. So what do you do when you have in resource poor countries compared to, say, the US or Europe, which is seen as much more research rich? And I was heartened, though, last year, and I don't know if you were too, by at least the WHO coming out with the essential medical list, and including for the very first time 3 MS disease-modifying therapies. So I think that is a beacon of hope, and hopefully it will learn to bigger and stronger discussions about MS across the world.
Yeah, I think you're absolutely right. For my listeners who may not be familiar with that WHO list of essential medicines, many countries base the medicines that they will pay for, that they will bring into their countries, on that list. So having 3 MS disease-modifying therapies is certainly a step toward bringing those medications into areas that don't often have access to them at all.
And thank you very much for clarifying that, because I think sometimes it is difficult to keep touch with what's going on in the world. And I think, from where I'm speaking, I don't even have to think about getting access to a DMT, or, that has to be off label, or it has to be a generic label. But again, these are expensive medicines. And what happens if you cannot get access to them, or you can't afford them?
Just a couple of weeks ago, it was reported that nearly half the people with MS who apply for disability benefits in the UK are routinely rejected. What do you suppose is happening there? And what has to change, I guess, is the bigger question.
I think there has been a bit of a pull towards shifting to disability payments and saying that we have to cut down on them. And I think at the same time, there is also a shift in the other direction, saying not all disabilities are affected by mobility. There are some invisible. This constrains people going to work and cognition issues. And at the same time, we have people living longer lives. So I do think there is an inherent conflict there. I do think there is a pushback on what we call PIP, which is personal independence payments. And it'll be very interesting over the next year or two to see whether or not there is a shifting in that.
I heard you mention the fact that people are living longer. Today, there are actually more people living with MS who are over the age of 65 than there are people living with MS under the age of 45. As the MS population ages, is enough attention being paid to treating MS in older adults?
I think that's a fascinating question, John, and it's one that probably 20 years ago we wouldn't even be thinking about discussing. But I think it's a result of two things happening. As a general population, we're living longer, and especially with the introduction of, what are we up to, nearly 20 or up to 20 disease-modifying treatments, and people with MS are doing very, very well on that. So we've seen a whole shift. People are able to live better lives, more normal lives, and also they're able to stay and work longer. But I think the flip side is that so many clinical studies used to end or traditionally end at 55 or 60. So I think the information there, or the data and the research, just isn't there. Is it worthwhile for us for a neurologist to keep a patient on a disease-modifying therapy after the age of 55 or after the age of 60 when there doesn't seem to be any visible sign of inflammation? And on the flip side, there's patients like me sort of saying, hang on, I'm 58, I've been doing okay, could you please keep me on? So I think it's a real balancing act. And I also think there is the issue of comorbidities, and because as we get older, all of us get older, we tend to collect various other health issues, be it, I don't know, depression or anxiety or raised blood pressure, and it's about, again, treating things like that at the same time, which I think can also be challenging for the MS scientific community. I also think there's something that I know we've talked about in the past about cognition and MS. And again, we know that with an aging population, you do tend to get more cognitive problems. You can't find the right word, or following a conversation, or multitasking suddenly becomes more of an issue. And we know we see that in MS. So I think it must be quite difficult for researchers or a doctor to pick apart saying that we can blame on the MS, or actually it's a normal part of aging, and you will see that coming along.
I was very encouraged to see that the International Advisory Committee on Clinical Trials in Multiple Sclerosis recently held a workshop specifically focused on aging in MS. And I think that coming out of that workshop, we're going to see a lot of initiatives that are exactly tuned to the sorts of things you just mentioned.
No, I thought that was fascinating. I'm just going to say as an aside, I think the timing was absolutely superb. And I was reading something very recently about, is it Professor Xavier Montauban, who's in charge of and he wrote in Ectrans recently, he had, a few weeks ago, he diagnosed an 89-year-old woman with MS. Because she'd had her first relapse. I mean, yeah. And he said, quite interesting, we'll probably keep her on a DMT for a year or two and then see. Whereas he said it would be very different if we just diagnosed a 28-year-old person with MS, because then the continuum will be much, much, much longer.
Switching gears a little bit now, Dr. Nara Michelson, who's a multiple sclerosis fellow at Harvard, has written a thought-provoking essay where she describes the similarities she's observed in treating women who had been newly diagnosed with MS and women who had been victims of domestic violence. Now, as someone living with MS who's also focused on women's health issues and MS, what are your thoughts about Dr. Michelson's essay?
Oh, I thought it was superb. And, I thank her so much because it was so eloquently written. And I thought she did such a superb job of sort of comparing and between her patient, on the intimate partner violence, and also the ones she was telling or diagnosing and telling them, you have an MS diagnosis, and how they're feeling very vulnerable, very trapped in their own bodies. And I thought it was worth mentioning that in the UK, we've gone a step further. And what we've done is at the University of Leeds and also the University of Nottingham, as of 2 years ago, have set up MS and domestic violence and abuse research initiative. Because we do know that disabled people are much more vulnerable and experience domestic violence and abuse much 2 or 3 times, and it could be even higher than people among the general population. And we also know that women do tend to get MS more. And I think Professor Helen Ford and Professor Nikos Evangelou noticed during COVID, during the lockdown, that they were seeing a lot more patients that were suffering from domestic violence and abuse. And they wanted to find out more because there isn't any sort of clear guidelines of what to do next. So we've set up this research initiative looking into it from the point of view of women with MS who have been victims and survivors, and also the healthcare professionals, MS healthcare professionals. Do they know how to deal with it? Is there a clear pathway? Is this something we can turn into a toolkit for the future? And I also think at the same time, when we think of domestic violence and abuse, we immediately think of, say, intimate partner violence. But we're also learning that the abuse can also be economic, say, people getting their credit cards taken by their carers. It can also be very coercive, taking away their mobility aids and their wheelchairs, and also oftentimes it can be with women with their children who have this huge fear of losing their children, because their so-called carer or person looking after them tells them they're worthless and they will lose contact. Also on the flip side is a lot of the domestic abuse refuges and shelters in the in the UK are not built for people with disabilities, access ramps, special rooms, bathrooms. So it is a real issue.
It is. We've had a similar study done here in the U.S. that unfortunately revealed the very same sorts of information that you learned in the U.K. about domestic violence taking place between a partner and someone and their partner living with MS. As unfortunate as that is, I haven't seen the kind of initiative happen in the US that you're seeing take place in the UK. So hopefully that's a situation that's going to change, because living with MS comes with its own set of challenges, and we certainly don't need to heap more on top of that. You're the lead author of a paper that calls out neurologists for what's been called medical gaslighting. Can you explain what medical gaslighting is?
Okay, medical gaslighting is it's when a patient, because we're talking about medical gaslighting, a patient finds that their symptoms or their reactions are dismissed, ignored, or pushed aside by their medical professional. And so they find it, they end up leaving their office, either believing they weren't believed or undermined, and it's in its greatest form. It can mean that possible diagnosis like MS can continue to go unchallenged, or there's a misdiagnosis, or it takes longer to get diagnosed and to receive treatments. I would like to say I think there's some real horror stories out there, but I do think on the flip side, there is a growing awareness of medical gaslighting. And also, and I certainly haven't come up with recommendations, but I've been reading recommendations about things you can do to make sure that when you go to a healthcare professional, that you feel that you are listened and your considerations are taken seriously.
Well, I'm glad you've brushed up on those because I was about to ask you for your advice for someone who feels as if they're not being heard or their concerns aren't being addressed or even acknowledged by their healthcare professional. What steps might they be able to take?
Well, I think it's a number of steps, and I don't want to suddenly go to turn around and say all medical doctors tend to gaslight. I mean, I think we also must be aware that doctors are under an awful lot of pressure. They've got to see an overwhelming number of patients. They have a limited time period. They're probably typing at their keyboards at the same time, and so it is. I want to say a lot of this I don't think is intentional. I think it's just a system under strain. But I would make a couple of recommendations if you feel that your healthcare professional is not listening to you. I think we all have to be aware that time is limited. So probably come in with the top, say 1, 2, or 3 points you'd like to make, and write them down, because sometimes when we get in front of a healthcare professional, we tend to ramble. Do that. You can also take along a partner with you, a family member or a friend, just for support there. You might want to but make sure you ask permission to record the conversation, because I don't know about you, John, but sometimes in medical settings, you tend to forget what the doctor has said to you. But obviously do ask their permission, say, look, I'd like to record this conversation. Is that all right with you? I also think that what you can do is to make sure that your concerns are heard. So you, at the end, say, what are the next steps? Can we set up an appointment for that? Should I see another specialist? I think that's just a bit of a nudge to say, I am in the pipeline and this will get looked at. And also, I think if you continually feel that you're not being heard, perhaps you can think about it, moving on to a new healthcare professional or making a complaint.
Well, Rachel Horne, thank you for your continued efforts to shine a bright light on inequities in healthcare, as well as your efforts to ensure that the MS research and clinical communities are focused on women's health issues in MS. Thanks again for talking with me today.
Oh, and thank you very much, Sean. It's always a pleasure to be on your show.
That's going to wrap up this episode of Real Talk MS. Real Talk MS is powered by the National MS Society. And you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/352. You'll find that link in today's show notes, so you can easily copy and paste it right into an email or a text. And if you have a minute, I hope you'll visit the Apple App Store or the Google Play Store and download the free RealTalk MS app for your iOS or Android smartphone or tablet. It's the best way for us to stay connected. The app will automatically download the latest episode of RealTalk MS. You'll be able to access any of our past episodes. You'll be able to save your favorite episodes, and it's a great way for me to share bonus content with you. The app is free, so I hope you'll download it today. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.